Good evening, everybody. Welcome to this UROwebinar, which is dedicated to how to handle complications of intravesical therapy. And this evening, we have a really outstanding faculty, which will present complications in BCG. Professor Tommaso Cai, who is acting director at Santa Chiara Hospital in Trento, University Hospital, but he is also a panel member of the guidelines on urinary tract infection. So he will discuss about BCG. And then Professor Vichis, which is the former chairman of the muscle-invasive bladder cancer guidelines, will discuss how we should manage a complication of intravesical chemotherapy. And finally, Dr. Lydia Makarov, which is chief executive of the renowned patient organization Fight Bladder Cancer, will discuss about the importance and the strategies through which we should inform our patient. So please, you can use the chat to submit your questions, and we will try to address as many as possible. If not possible during this session, we will try to address online these questions that you may submit. Okay, and now let's start with Professor Tommaso Cai. Please stay until the end, because then we will have to announce an initiative which is very interesting.
Good evening, ladies and gentlemen. Many thanks to the European School of Urology Board and to Professor Paolo Gontero for inviting me to speak about an important field in everyday urological clinical practice, how to manage complications of BCG. I have no potential conflict of interest to report for my speech, and this is my agenda for today. First of all, I would like to start with the mechanism of action of BCG in order to understand in deep the risk of development of BCG complication. Moreover, show you the most common complication of BCG therapy, divide them in early and late complication. Moreover, discuss with you a clinical case, and finally give you some recommendation for everyday clinical practice. To begin, let me to start from the mechanism of action of BCG. BCG is an attenuated strain of Mycobacterium bovis that in 2019 has been approved by Food and Drug Administration as adjuvant therapy for recurrent non-muscle-invasive bladder cancer. BCG, as you will know, can directly or indirectly cause damage to bladder carcinoma. BCG is able to perform direct damage to bladder cancer cells through several mechanisms: through membrane damage, through stimulating apoptosis, through creating an oxidative stress around the tumor and then stimulate apoptosis. Moreover, BCG is uptaken by urothelial cells through macropinocytosis regulated by several carriers. The direct damage to bladder cancer by BCG is the basis of local symptoms, such as, for example, of hematuria. Moreover, BCG is able also to perform the indirect damage to bladder cancer, stimulate the activation of the innate immune response, for example, to stimulate the production of interleukin 2, 8, 6, and 10, that are the basis of the development of systemic complications such as fever and other systemic complications. Moreover, BCG is able to stimulate an adaptive immune response. But as you all know, we have a lot of predisposing factors endorsing complication. For example, immunosuppression. Immunosuppression is an important risk factor to take into account in everyday clinical practice. And as you all know, BCG should be used with caution in patients, in immunocompromised patients. Moreover, the age of the patient in another aspect to take into account. In patients older than 18 years, we need to pay a lot of attention. Moreover, the presence of comorbidities such as diabetes and hypertension who represent a risk factor for development of complication after the therapy. But what about the prevalence of BCG complication? We know that up to 70% of patients reported local symptoms, and we know also that about 30% of patients reported systemic complication. But we know also that the serious complications are incurred in less than 5% of patients. And several authors reported that there is not significant difference in terms of toxicity or risk of complication among the different BCG strains that we regularly use in everyday clinical practice. Moving to the classification, we can classify the BCG complication in early or late complication, in genitourinary complication, or systemic complication. Moving to the genitourinary complication, we can have early complications such as cystitis, prostatitis, and epididymitis, and kidney infection. And we have also late complications that require the surgical approach, such as bladder ulceration, bladder contracture, and urethral obstruction and stenosis. Moving to the systemic complication, among the early complications, we have the allergic reaction, fever, and miliary pulmonary tuberculosis, and the severe BCG sepsis that require immediate admission to the intensive care department. Among the late complication, the late systemic complication of BCG therapy, we have infection, hepatitis, reactive arthritis, and other more rare complications. Moving to the clinical case, I would like to show you an interesting case that we have had in the last year. 81-year-old patients affected by controlled diabetes and with irritative symptoms, with irritative lower urinary tract symptoms and perineal pain. He reported only a previous episode of macroscopic hematuria. He not have a history of lower urinary tract symptom due to BPH, and he no reported any drugs related to lower urinary tract symptom due to BPH. He reported previous bladder cancer and a BCG intravesical instillation, a 6-week induction schedule of BCG. The physical examination was substantially normal. The urinary dipstick was positive for leukocyte and nitritis, and the ultrasonography of abdomen was negative. He was discharged from the emergency department without any urological consultation or any infectious disease consultation, with the following therapy: ciprofloxacin 1000 milligrams per day for 7 days, and without no other suggested investigation. But what happened? 3 days after, he was admitted again to our emergency department with severe urinary tract symptoms and severe hypotension. The physical examination was, however, normal, and he had a reduced vesicular rumor on the check auscultation. Finally, the infectious disease consultation was required, and the infectious disease physicians suggested the test for tuberculosis, but the quantiferon was negative. The intradermal MAN2 test was not positive, and without any significant diagnostic finding. But the ED physician suggested the CT scan of the thorax, abdomen, and pelvis in accordance to the international guideline. And as you can see in this picture, the CT scan shows an extensive nodularity in both lung with the miliary pattern. Moreover, due to the persistence of urinary tract symptoms, the patient undergone 2 urological consultation and the digital rectal examination showed a prostate with enlarged prostate and collicutive zone, and the urologist suggests to perform an immediate transrectal ultrasonography of the prostate, and the ultrasonography show the presence of prostate abscess. The patients underwent several tests for diagnosis of tuberculosis, such as Mycobacterium test in the urine, the bronchoalveolar lavage, but finally, after the PCR of the urine, the patient was diagnosed by the infection of Mycobacterium. The patient has been treated according to the international guideline under the supervision of infectious disease physicians, and after 6 months of therapy, the outcome was positive for the patients without any significant and severe complication. But what are the key points of this clinical case? First of all, the need for considered all risk factors related to the high risk of developing BCG systemic complication. This patient was 81 years old man. The patient has diabetes and hypertension, and moreover, we need to stress the fact that we need to consider and the suspicious of BCG prostatitis in all men undergone to BCG treatment. Moving to the recommendation for the everyday clinical practice, we need to stress that BCG complication as very frequent in everyday clinical practice, and some complication of BCG treatment can be very serious for the patients with important sequelae and consequence. We need to stress to consider all risk factors in all patients who had undergone BCG therapy and manage it appropriately. Regarding the suggestion to manage genitourinary complications, for example, what about the management of cystitis related to BCG treatment? We need to prescribe anti-inflammatory drug, of course, but we don't forget the principle of antimicrobial stewardship. In particular, we need to prescribe antibiotic only in case of suspected bacterial cystitis, and urinary culture is mandatory in all patients with irritative avoidance symptoms in case of cystitis, for example. What about the late complication after BCG therapy? Of course, we need to have a ED physician's consultation in order to start an early treatment, and probably we need to plan also a surgical approach at the end of the anti-tubercular therapy. In case of symptomatic prostatitis, an infectious disease consultation is required in order to start the specific treatment, but also the treatment with the fluoroquinolone is necessary. We need to can discuss about the surgical drainage of the abscess in case of prostate abscess, but we need to discuss the single patients. In the case of a kidney infection, we need to start early the treatment in order to avoid severe complications such as BCG sepsis. In case of severe and late complication, we need to stop the BCG treatment and consider not indicated the BCG for these patients. In case of severe systemic complications such as fever, we need to consider an antibiotic approach, a broad-spectrum antibiotic, in particular in order to cover gram-negative bacteria, and also enterococcus, which is very frequent in prostatitis concomitant to the BCG infection. For the specific pulmonary infection of BCG, and ED consultation is mandatory in order to start the treatment. In all cases of systematic complication, no future BCG therapy is indicated. In BCG sepsis, the BCG sepsis is very rare, of course, and is an emergency and required an admission to the intensive care. In the last version of European Association of Urology guideline on muscle-invasive bladder cancer, you can find all practical recommendations to manage the complication of BCG. I would like to start two important aspects of this guideline. The guideline suggests to keep in mind all principles of antimicrobial stewardship. In particular, they suggest to perform an urinary culture and treat only patients with suspicions of bacterial cystitis with antibiotic. And it's very important to keep in mind that in case of hematuria, and several episodes of hematuria, we need to consider the presence of recurrent or relapse of the treatment. And in the guideline, you can also find all suggested treatment also for the systemic complication. I would like to conclude my presentation to stress the need to improve our adherence to the principle of antibiotic stewardship, because the management of BCG complication required an adherence to antimicrobial stewardship, and we need to keep in mind that our guideline stick to the European Association of Urology guideline in everyday clinical practice. Many thanks for your attention.
Thank you very much, Professor Kai, for this very clear presentation. And so far we have not received any questions, so please, I would encourage whoever of you wants to submit through the chat any comment, you are more than welcome to do so. Before we move to the next presentation, Professor Kai, you were mentioning the use of antibiotics in patients with the suspicions of bacterial cystitis. Now, when you have a severe urinary symptoms suggestive for an infection during BCG treatment, and you do not have a culture, what would be your antibiotic of choice?
Thank you, Paolo, for this very important question, because it's very important to keep in mind the principle of antimicrobial stewardship, of course, but in case of suspicious cystitis after BCG instillation, we need to use fluoroquinolone, because fluoroquinolone, even if it is not indicated for the treatment of uncomplicated cystitis, is able to act against BCG. And in the suspicious cystitis, we need to use a fluoroquinolone. High dose also of fluoroquinolone, for example, ciprofloxacin, 1,000 milligrams per day, or levofloxacin, 750 milligrams per day.
So I think
only in case of severe symptoms with febrile UTI, febrile urinary tract infection, we need also to consider a broad-spectrum antibiotic, such as third-generation ciprofloxacin, but only in case of febrile infection.
So this is, I think, is an important message, because it comes from an authority like you in the guidelines panel for urinary tract infections, because we know that there is a EMA restriction to the use of quinolones in the absence of culture, but as you are mentioning, here we are talking about a complicated infections, and so I think we can look beyond this restriction. And there are actually some questions coming up, but I think we only have time to do one, and we try to readdress the question at the end. One of these questions, what are the alternatives to fluoroquinolones? There is a question said that in Germany we must not give them unless it's the only choice because of the side effects on the tendons. So I think it's more or less the same. So maybe this is related to the EMA regulations. And the question is, if you cannot use quinolones for whatever reason, what would be your second choice? I think I can translate the question in this way.
Thank you. A very important question, because if fluoroquinolone is able to act against BCG, and however, in case of severe infection, we can use also the tazocin, piperacillin, and tazobactam, for example, all third-generation cephalosporin in association with aminoglucoside. But also, we can remind also only in case of severe febrile UTI and known in uncomplicated urinary tract infection. The last point is, please avoid the use of fosfomycin prometamol in suspicious of cystitis after BCG infection because is not able to act.
Thank you very much, Professor Kai. And we will probably come back later if we have time. And now, Professor Witches, the floor is yours to discuss about complications and how to handle in patients receiving intravesical chemotherapy.
Paolo, thank you very much. And of course, also the ESU, thanks for the invitation. I hope you can see my screen. And if I hear a yes, I'll go on.
Yes.
Okay, great. So I have to talk about the complications of intravesical chemotherapy. And fortunately, they're not as common as BCG. And fortunately, they're not as severe as BCG. But still, you can encounter some of those problems in daily practice. I have some totally non-relevant conflicts of interest. And if you really want to read a lot about this, because there is not a lot of specific literature or new literature, most of the studies on chemotherapy are comparative studies talking about efficacy, but not the side effects. So also the level of evidence is usually quite low. And basically, I think in common practice, it's best to just use common urological sense. However, if you really want to see something which is very interesting, this manuscript from 2021 from Koch and co-workers in urology actually is a very good review on side effects of both BCG and intravesical chemotherapy. If you look at general principles of chemotherapy, of course, toxicity can be local and systemic. Local toxicity is basically related to the intrinsic irritability of the drug solution, for example, the pH, and obviously also the drug exposure time and concentration. And systemic toxicity is related to the drug absorption, again, exposure, but also solubility and integrity of the bladder wall, because you have done a TUR, so keep that in mind. What's drug related? Well, this is again from the manuscript from Koch. You see basically that mitomycin C, which has a molecular weight of 334, so it's a sort of intermediate big molecule. You see what you probably know, some fever, some malaise, skin reactions very often. Then, of course, the local symptoms, because it's not very nice to have something like that in your bladder. In summary, I think contact dermatitis or allergia you will see in 5 to 10%. Malaise you will see in 5 to 50%. And of course, bladder irritation is the most predominant problem in 30 to 40%. Talking about patients, this picture here was from my neighbor who was treated by mitomycin C by myself. And after the 4th installation, he in the evening came to me and showed me this. And of course, this was a contact dermatitis, which means that you can't go on with mitomycin C because then it's an allergia. Gemcitabine is a quite small molecule. The molecular weight is 263, which means that there is a little bit more systemic toxicity. You see that here, even neutropenia and fever. To be honest, I haven't seen that a lot, but it's possible. And also, of course, again, the local toxicity when you have chemotherapy in your bladder. So in summary, not that many data. There is systemic toxicity, but it's not very frequent. But again, bladder irritation, chemical cystitis, you will see in 20, 30 to 40%. Then you have epirubicin. It's a big molecule. The molecular weight is 543. So it means there's absolutely no systemic absorption, which is nice. You see here that there's very, very few systemic side effects. But again, you will have your local toxicity, chemical cystitis. I think that's the most frequent side effect. And in general, very, very seldom systemic toxicity. Maybe when you have just had a TOR, that's of course possible. And then also bladder irritation, again, a little bit less frequent than with mitomycin C, but you still have that also as an option. TOR related, well, of course, you have to take care. If you do a single post-op installation after the TOR, look at the guideline. It should best be given at the day of surgery, but then you still have your wound. All drugs are apparently equally effective, and beware of perforation. This is a case I had a few years ago. That was a guy which in the end had a TA low-grade bladder tumor that was resected. The perforation was not recognized, so he had the same day one installation of mitomycin C, and he ended up after a month having a catheter with a perforation here in the bladder, a fistula, which you can see here, and also a shrunken bladder. So I had to do a bladder replacement in this guy after one installation of mitomycin C. Something you also see in patients if you give one installation of mitomycin C, and that's without symptoms, but you see those calcifications when you look for the first time after 3 months in the bladder. Again, they are usually without any symptoms and they disappear, but still this is something that you can encounter and you have to take care. So if it's difficult to try to get this out of the way here now. If you don't have to do a single post-op installation, that does happen, logistic reasons, for example, in the United States, daycare admission, etc. Some people doubt about the efficacy. I don't think that we do that because it's proven. And there is, of course, also fear for safety. You look here at the SWOG trial with gemcitabine, 165 patients in each arm. You see that the maximum rate and number of patients with side effects was very, very limited, and actually the same as in the group that only received saline. So believe me that a single post-op installation, if you do it well, of course, is very safe. We checked that also in the Netherlands. It's a large observational study with 25,000 patients. There are some patients that had a 14-day complication and a 30-day mortality risk. We checked all those patients, the files, and in the worst case scenario, the 3-day mortality risk was 0.02%, so very, very low, only a few patients and severe complications, and they still might have been caused by, for example, the TOR, was 1.8%. So again, single post-op installation can really be considered not only effective, but also it's a safe treatment in patients with low to intermediate risk bladder cancer. Prevention or treatment, of course, if you have a TOR and maybe a perforation, it's always a very good discussion issue during the non-muscle invasive bladder cancer masterclass, which also is being organized by the European School of Urology every year. And every year we have discussions about what to do when there is a perforation. Almost always a transurethral catheter is enough. In case of an unrecognized perforation and intravesical chemotherapy on the same day, again, give those patients a transurethral catheter and observe them very closely. Certainly a case of an intraperitoneal perforation. If it's extraperitoneal, it's not that bad, but if you have an intraperitoneal perforation, you might run into problems with the bowel. I have seen once a patient with bowel necrosis probably after intravesical chemotherapy, although I also realized that the gastrointestinal surgeons also use intravesical or intra-abdominal chemotherapy for some of those tumors in the bowel. So whether that has been, in my case, due to the chemotherapy or maybe due to the TOR itself, I don't know, but I've seen it once. If you are afraid that there might be a perforation, you still want to do something, then you can also do a continuous saline bladder irrigation. Again, here's a large review, and you see if you do that and compare it with intravesical chemotherapy, it's safe. You will have less macrohematuria, less urinary frequency, less irritative bladder symptoms with continuous saline bladder irrigation, and the meta-analysis has shown that it is quite effective, maybe just as effective if you do that for 24 hours as one installation of chemotherapy. Treatment, if there is side effects of chemo, now in my cases, obviously you might use some anticholinergic drugs or painkillers. I think that's probably been done by everybody. Maybe you should delay installation if the symptoms present from prior installation. Maybe it's delayed for 1 or 2 weeks. And in severe cases, stop the medication. You can use oral steroids or even, and I've never done the last, but you read it everywhere, intra-pulsar corticosteroid injection may be helpful. Again, I haven't done that. I usually stop the medication, give some painkillers, maybe some steroids, but usually that's enough to treat the side effects. Again, here you see a very nice algorithm for mitomycin C, because that obviously is the drug that is used most. That's another article in Bladder Cancer in 2017. And you see these things that I also talked about, antihistaminic steroids, resect ulcers, etc. So I think that makes sense, but again, use your clinical practice. In the manuscript of Koch, there is a very large table, which is really helpful if you run into trouble, what you have to do post-EUR, in office within 24 hours, and even after 24 hours or 48 hours, how best to address some of those side effects. Of course, you can't read this table, but you can find that in the manuscript of Koch. There are also newer strategies, Gemdosi, that's being used in the United States. In Europe, I guess it's also used more and more. There are not that many manuscripts about that, but one of the first publications on that has shown that actually the side effect profile is not that bad. Adverse events were reported in 14 out of 83 patients, so that's 70%. Usually actually quite low in Clavien Dindo, 1 or 2. Urinary tract infection, 1 patient only required hospitalization for IV antibiotics, and no Clavien Dindo, 3 or more events. So I think this combination is as toxic, or not as toxic, not very toxic, just like the drugs when you use them separate. So combination is not a major issue. And we looked at Synergo, so the chemo hyperthermia. We published that. We did a comparative trial, 100 patients in each arm, almost 24 hours results. You see a little bit better recurrence-free survival after thermal chemotherapy. But the side effect profile of BCG obviously was more systemic, like fever, etc. But of radiofrequency-induced mitomycin C, Synergo, you have, of course, more local side effects, because not only you have chemotherapy in the bladder, but the bladder is also heated to 42 degrees. So you see here that some of the side effects are really local, which is quite easy to understand, that it is more pain during sessions, for example. Of course, you don't have that during BCG, but you do have that during chemohypothermia. What you also see, if you do that, maybe not with the Synergo machine, maybe with a HIVEC machine, you see a quite severe posterior wall thermal reaction. So I've been doing this since 2001. And the first patients I saw after 3 months, I really was shocked, like this is an invasive tumor. So I've taken biopsies out of this, but it's just necrosis and there is no vital tissue in there. And if you just follow that, it actually disappears after 3, 6, 9 months, because then the frequency of installation is much less than in the initial induction phase. So it looks dramatically, but fortunately there's no issue. Then you have HIVEC, which is maybe a little bit less effective than Synergo. You know that there have been 2 trials published, the HIVEC 1 and the HIVEC 2 trial. Here you have the HIVEC 2 trial, and adverse events with chemohypothermia were low-grade and short-lived, although patients were less likely to complete their treatment if you compare that to only chemotherapy. So probably a little bit more side effects after chemohypothermia than only mitomycin C. And if you look at the HIVEC 1 trial, you see that it is actually quite well tolerated. So I think in general, HIVEC basically doesn't really increase toxicity. What about the pretzel? You've been reading and seeing that on all congresses and in journals. We did a phase 1 study in Nijmegen with gemcitabine. So that's a TAR 200. 12 participants, not a lot, but that was the first initial study. And you see, again, not that many side effects. No grade 3 or more side effects. Some of the patients had, of course, some urgency in dysuria, because obviously you put something in the bladder like you do a double J stent, which doesn't belong there. So patients have a little bit more local side effects, but that was quite low, quite minimal. And then the thermosensitive gel, which is now also used in the bladder. This trial was obviously absolutely underpowered, but you see some of the side effects of that UGN 102. It does increase local toxicity, but seldomly, again, serious. So my conclusions are no drug-specific toxicity, such as contact dermatitis and allergia from mitomycin C. I think that's the most important one. For all chemotherapy, you will have some local side effects as chemical cystitis. It will have expected bladder irritation, very seldom general toxicity, like myelosuppression. Single post of instillation is really safe, but in case of a suspected perforation, don't give chemotherapy, maybe give saline. Perforation and chemo means transurethral catheter and very close observation to make sure that you don't send the patient home the same day, but observe them at least for one night. For local problems, anticholinergic drugs, painkillers, and or delay usually is sufficient. The new unenhanced strategies, such as, for example, gemdosi, seems to have similar toxicity profiles, and enhanced strategies, the gel, the pretzel, logically have a little bit more local problems. That's what I wanted to say about intravesical chemotherapy complications, and thanks for the attention.
Thank you very much, Professor Wichis, for your very clear and comprehensive presentation. As you said at the beginning, of course, the complications of intravesical chemotherapy are much fewer than BCG and manageable. Before we proceed, there was actually a question which I think we would like to hear your opinion. It pertains probably particularly women. I mean, when they might have a contact with the skin with mitomycin or other chemotherapies, and the question is what would you advise maybe to use barrier creams? And there was also another question asking whether bleach or what other compounds could be used to neutralize the chemotherapeutic agent in the toilet.
So if you look at the last question, we use chloric fluid when you use BCG, not when you use chemotherapy. We have measured the amount of chemotherapy in the sewer very close to the hospital, and there is a lot of chemotherapy very close to the hospital. That's, of course, a problem. In ladies, you can use a barrier cream, vaginal barrier cream, to prevent some of the side effects, but still it's a contact dermatitis. So also males, you won't, well, maybe you will have less side effects, but you won't prevent them.
Okay, thank you very much. So I think it's better if we move to the last presentation. Dr. Makarov, we are very, very interested to hear the patient perspective. So I think that this is going to be very instructive for us. Thank you for accepting this invitation.
Thank you for the invitation. Yes, now we'll be speaking about the importance and strategies for patient information. These are my declarations of interest here. So I am the Chief Executive of Pipe Bladder Cancer, and I am the President of the World Bladder Cancer Patient Coalition. So how to communicate effectively. And here we have photos of 3 of my favorite clinicians communicating very effectively. So use clear, non-technical language, use visual aids and written materials, and encourage questions and provide thorough answers. So now I'll go through some of the side effects that the previous 2 speakers have talked about and give examples about how to communicate these to patients. So you might want to say something like, if you notice any discomfort or unusual symptoms, keep track of your feelings and inform us promptly. Feel free to ask questions and share any concerns. For severe pain, heavy bleeding, or high fever, contact us immediately. And this is how you can contact us. And then you give them the name and the email or the phone number of the person that they can contact, and whether or not there's a difference between office hours and non-office hours. So lethargy and fatigue. So most patients say that a day or 2 after the treatment session, they experience quite substantial lethargy and fatigue. So you want to tell your patients to expect this and to be gentle with themselves. You can encourage your patients to take rest, to take breaks, to stay hydrated, to eat well. And then you can also check in with them and monitor their levels of fatigue, and also tell them to seek support as well. So reach out to others and know that this is coming, that this is to be expected. Discomfort and low-grade pain can be quite common as well. So you can talk to your patients about using over-the-counter pain relievers. You can talk to your patients about relaxation techniques, deep breathing and meditation, and low impact activities like exercise, swimming, and walking. You can monitor and manage their pain medications, consider referring your patients to physical therapy, and discuss lifestyle changes as well. So diet and making sure that they have quit smoking as well. Many patients experience depression, memory loss, and brain fog. This is a very stressful time for many patients. So you can encourage your patients to seek support from a mental health professional, engage in mindfulness exercises, join support groups, ensure adequate rest, and perhaps establish a new routine, a new normal. You as urologists, you can refer to a mental health professional if you have that within your hospital. Consider prescribing, talk to your patients about whether an anti-anxiety medication or an antibiotic, an antidepressant would be appropriate, suggest mindful exercises, and of course refer to support groups. There are many different support groups, both locally, nationally, and internationally. Many patients have also reported increased side effects about menstrual periods as well. So you might want to be talking to your patients about whether or not they experience worse side effects around their menstrual periods. If so, encourage them to use heat pads to track their symptoms, and then see if any medications are appropriate, or discuss scheduling treatments away from menstrual periods as well. So just be aware to have that discussion with your patients and ask those questions. When we go to urinary issues, infections, and inflammations, once again, please encourage your patients to drink plenty of fluids, maintain good urinary hygiene, perhaps consider bladder training, but then also tell them that if they have any of these symptoms, report their healthcare team immediately. High fever, intense pain, urine that has a strong odor or pus, and then consider prescribing medications as appropriately, check in with patients, and then as always, keep calm and refer to the EAU guidelines that we've heard earlier, and make sure that you are treating any of these issues according to the European Association of Urology guidelines. Then there's also the issue of allergic reactions and autoimmune responses as well. So once again, make sure that your patients are aware of the danger signs: redness, warmth, or tenderness in the joints, inability to move a joint or loss of mobility, eye pain, redness, or blurred vision. Tell them to report these symptoms immediately, and then you can use the EAU guidelines to see whether prescribing medications is appropriate, whether these patients need to be referred to a rheumatologist or other specialist, and then see whether or not the treatment needs to be adjusted or discontinued according to the guidelines. We've also heard about more severe reactions as well. So once again, the patients need to be aware of the symptoms that they should report immediately: high fever and chills, severe fatigue, persistent cough, night sweats, difficulty breathing. And then we've heard some great examples here of the appropriate diagnostic tests that you could do, whether or not patients need to be hospitalized. And once again, please involve other specialists. So if we talk now about patient information, why does it matter? It empowers patients to manage their own health. It helps patients understand potential adverse events, and it reduces anxiety and improves overall patient outcomes. And then here we have one of our patient groups from Norway. And then this is our patient group from Sweden, and the importance of using materials created by patients. These materials resonate more with others going through similar experiences. They address the emotional and practical aspects of living with cancer, and peer support and shared experiences foster a shared sense of community and belonging. And all of the patient groups associated with the World Bladder Cancer Patient Coalition, all of the patient materials are produced in the local language, but they're also produced in collaboration with the healthcare professionals in those countries as well. So those are all in line with national and European guidelines. Also, ask your patients what is their preference for information delivery as well. So you can say, to ensure you receive information in the most helpful way, what format do you prefer? Printed, web page, videos, online forums, support groups. And you can even give them examples. So in the UK, for example, these are some of the printed patient information booklets that we have. For example, what is the TURBT and whether it's non-muscle invasive bladder cancer. And in the UK, we print and post these patient information materials to all the urology departments in the UK. They're also available for free download. And there's many others available in local languages as well. And you can also find the EAU patient information that is translated into many different European languages. So you can give your patients information in their native language. Videos are also very helpful because patients can watch them when they're ready. They help patients understand what to expect during treatment. And these videos can also highlight common adverse events. So you can see here Hugh Mustafa speaking about BCG and the common side effects. And then patients can stop and start this and listen to this in their own time. Patient stories are really vital as well. They provide empathy and understanding. They reduce feelings of isolation. They offer practical advice and solutions for daily challenges. You know, what sort of underwear should you use? What happens at nighttime? What is it like before, during, and after a procedure? And they also inspire hope and motivation because you can see different patients, for example, this one from the Netherlands, sharing her motivation and how she got through treatment. There are also online peer support forums. These are some of the Facebook forums that are available in Europe. So there are Facebook forums available currently in Europe, in English, French, Italian, Norwegian, and Swedish. And these are all run by professional patient groups, moderated 24 hours a day. And they also have medical professionals on it. So this is a great way for patients to receive peer support as well. So you could say something like, I recommend joining this online peer support forum. These platforms allow you to connect with others who are going through similar experiences, offering valuable advice, support, and a sense of community. Here is their website. And don't forget to involve the family and caregivers as well. So the carers provide additional support and reassurance. They help managing treatment and side effects at home. They enhance communication and decision-making process. And it's often the family members and the carers who will sort of nudge the patient to say, I think that side effect is quite serious. Perhaps you really should be calling your healthcare team and reporting it. And then also the carers often come to the appointments as well, are responsible for making the appointments, and often are quite involved in the treatment decisions as well. So finally, there are many patient organizations in Europe dedicated to bladder cancer. So these are the ones that are English, French, Italian, Norwegian, Dutch, and Swedish. If you would like to start a patient support group, if you know a patient in your country who is very passionate, then feel free to work with them and the World Bladder Cancer Patient Coalition, and we'd be very happy to help you set up a support group as well. So this is something that you could say to your patients. I recommend connecting with our National Bladder Cancer Patient Organization, which provides excellent resources and community support. They can offer additional information and support to help you navigate your treatment journey. Here is their phone number and website. And as a summary again, these are some of the European bladder cancer patient organizations, and then you can go to the World Bladder Cancer Patient Coalition website to see the list of many of the national bladder cancer organizations from around the world. Thank you.
Thank you very much, Dr. Makarov. You highlighted how I think the communication with the patient is crucial, and unfortunately, often it clashes against the lack of time that we all have as a physician. And I think that you have also provided a lot of tools that can really aid to optimize this strategic communication. And you also pointed out that there are these national organizations, not in all countries. And so the first thing is that where there is a national organization, I think whoever is dealing with bladder cancer should take contact, because they will be able to provide a lot of information, leaflets. And for those nations where there is not a known organization of patients, you have just reminded that, for instance, Fight Bladder Cancer is providing translation in several languages of these leaflets. And so maybe what should be the process? Just to log in your website and submit the questions or ask for receiving this material, what would you recommend, Dr. Makarov?
Thank you. Yes, so you can email info@worldbladdercancer.org, and we have access to many different translated materials. There's also the EAU patient information portal that has a lot of translated materials as well. Or you can reach out directly to me, lydia@bladdercancer.co.uk, and I'd be very happy to share any translation that we have available in your local language.
Thank you very, very much. And I also want to remind that Dr. Makarov is actually the patient representative for the non-muscle invasive and upper tract bladder cancer guidelines. And so thank you very much for your dedication, which I think the close relationship between urologist and the patient organization is essential and for a successful treatment. We are actually running perfectly on time, so we still have around 7-8 minutes for the discussion. I would like to remind that this webinar is actually supported by an unrestricted grant from Photocure. So we have to thank also Photocure for this support to this educational event. And going through some of the questions that I have spotted, maybe somebody of you has been able to address these at the moment, but there was one concerning, and I would like to ask Professor Kai, how can we prevent and reduce BCG complications? Could you just give some bullet points on what are the most important things that to reduce? You have shown that some complications are very rare, but really dramatic, like the systemic infection due to BCG.
Yeah. But thank you, Paolo. I think that the presentation for Dr. Makarov is very crucial, as you highlight, because I think that the patient engagement is one of the most important aspects that we need to achieve in order to prevent, for example, BCG complication, rehydration, rest, and so and so. Moreover, I would like to stress some aspects related to the patient's characteristic. We, as a urologist, we need to highlight and to consider the risk factor related to the patients, the age, comorbidity, and so and so. And we need also to keep in mind the history of urinary tract infection in order to prevent the cystitis related to the BCG. It is important to consider it, but it is also important to consider the role of asymptomatic bacteriuria. I read a question about asymptomatic bacteriuria in patients to undergo BCG treatment. Asymptomatic bacteriuria is not a risk to develop infectious complication after BCG. In fact, we did not suggest to perform urinary culture before the treatment. This is very important. Another new approach to the preventing and management of a complication related to the BCG infection is the instillation of hyaluronic acid. We have an Italian experience in which the authors perform an instillation of hyaluronic acid between the BCG instillation. I think that it could be a role in the prevention of BCG complication, but only in patients at high risk to develop a complication.
Is there any role for steroids for, of course, complications due to chemotherapy?
Yeah.
Or anesthetic?
Yeah.
Do you have any experience?
I prefer the anti-inflammatory drugs, of course, because we have a lot of patients with a lot of comorbidity, diabetes, and so. And I prefer to not use steroids. We have some experience with the steroids by instillation, but I think that this practice increased the discomfort for the patients, and we need also take into account the discomfort of the patients by the catheter. Anesthetic agents, no, is the same about installation of steroids. If we can use some installation, we can use hyaluronic acid, because hyaluronic acid has a rationale and scientific rationale in the management of recurrent urinary tract infection.
Okay, this is very good. And so also thank you very much for highlighting this important message which came from a question. So asymptomatic bacteriuria is not a contraindication to BCG and should not be treated with antibiotics before giving BCG. Is that correct?
Yeah,
okay.
I would say
absolutely
yes.
Correct.
Fantastic. Does age affect the indication for BCG? If you have a high risk bladder cancer patient, which is over 80, would you just consider alternative intravesical treatment than BCG because of the age and the risk of complication, or BCG has to be the first line treatment in this case? Fred, what do you?
Well, you know, basically BCG is more effective certainly in high risk patients, and of course, if you first give chemotherapy, you have the risk of progression. So I would certainly try to give BCG. Of course, look at side effects. I sometimes combine that with ofloxacin, 200 milligrams the evening of the installation and the next morning. But my choice would be BCG, and hopefully, you know, if it doesn't work, then of course you can try mitomycin or epirubicin. But I would start with BCG.
So BCG remains less effective in the elderly, but still more effective than intravesical chemotherapy.
Yeah, you can even go to start with 1/3 dose, which you know from the large EORTC trial has a little bit less efficacy with regard to the recurrence rate. To my surprise, by the way, in the EORTC trial, it also didn't have less toxicity, which I think is funny, because if I reduce the dose, usually these patients have less side effects, but something to keep in mind.
I think we are nearly at the time to close. I would really like to thank you very, very much for your outstanding presentations. Very, very excellent educational content. Thank you very much. And I think it has been also very, very interesting and an honor to have Dr. Makarov providing also the patient perspective, which we should never forget during our practice. And finally, I just would like to announce the next webinar, which will be held the 5th of November. But this webinar will have a very, very special format. It will be a presentation of 3 cases on nightmares in bladder cancer. So any type of bladder cancer, but these cases will be presented by yourself. So please, between 15th of July and 15th of September, anybody of you who are listening, anybody of you who is a member of the EAU will be able to submit through this email, educationalonline@uroweb.org, a clinical case which should not last more than 10 minutes. Of course, pictures are always welcome for these clinical cases, and there will be a selection process. So only 3 will be selected, and you will present the cases during the webinar. And of course, in return for this service, you will actually receive a free registration to the next EAU Congress in 2025. So I would encourage everybody of you to submit cases, which of course will have to be, let's say, special cases, and undergo the review process. You will be notified within the 13th of October about the results of this selection. So I take the opportunity to thank you very much, and also to thank the EAU organization, Tessa in particular, for setting up this UROwebinar. Thank you very much to all of you, and have a nice evening.